Everyone today to the Rutgers Robert Wood Johnson Department of Medicine Grand Rounds. As a reminder, the video for most of our sessions, including today's session, is on the Department of Medicine YouTube website, which you can access from our website, rwjmsdom.org. Also on the website, we have listed all of our upcoming grand rounds, including next week's grand rounds given by our own Dr. Lian Chen, presenting on the role of the microbiome in inflammatory bowel disease. For today's session, the CME text code is 6685. During today's session, everyone will be muted, but we encourage as much discussion and questions as possible. We'll have some time during and at the end of the session for questions. So if you have any comments or questions, you can post them in the chat box, and also you can be unmuted to ask your own question if you prefer it that way. It's my privilege to welcome you all to our annual Robert Panos Lecture on Humanism and Professionalism in Medicine. Dr. Panos was former vice chair in the Department of Medicine at Rutgers. He was instrumental in establishing our Humanism and Professionalism Council in 1997 on the heels of ABIM's Project Professionalism. Our current HMP Council serves in an advisory role to our leadership and has established an excellent needs-based curriculum in the art of medicine. Our residents are recognized each year for their outstanding humanistic and professional attributes with an award in his name. He was the chair of medicine at our key hospital affiliate in Princeton for over a decade in the 1990s. A master of the American College of Rheumatology, Dr. Panos is a historian and an active writer. Before I introduce our speaker for today, I want to welcome Dr. Panos to our grand rounds and ask him to say a few words.
Thank you, David, for those complimentary remarks. I won't take too much time because I want to hear what Armstrong has to say. This lecture was established to be the cornerstone of our program in humanism and professionalism after I retired 13 years ago. We have a very distinguished speaker today, and Dr. Cohen will introduce her.
Thank you so much, Dr. Panos. I'd now like to introduce our speaker for today. We're incredibly lucky to have Dr. Katrina Armstrong with us. Dr. Armstrong is the Jackson Professor at Harvard Medical School and Physician-in-Chief in the Department of Medicine at the Massachusetts General Hospital. After graduating from Yale University and the Johns Hopkins University School of Medicine, completing her residency and a chief resident year at Hopkins, and completing a general internal medicine fellowship and Master of Science in Clinical Epidemiology at the University of Pennsylvania, she joined the faculty at Penn and became the chief of the Division of General Internal Medicine in 2008. In 2013, she was appointed as physician-in-chief of the Mass General Department of Medicine. Dr. Armstrong is an internationally recognized investigator in the areas of medical decision-making, quality of care, and cancer prevention and outcomes. In addition to her career in health policy and disparities research, Dr. Armstrong is a dedicated practicing internist with a longitudinal primary care practice and on the inpatient general medicine services. Diversity and inclusion are central to Dr. Armstrong's leadership, including her award-winning roles in the advancement of women, her commitment to programs to support diversity across faculty and trainees at MGH, and her research leadership in health disparities and community-based research. Thank you, Dr. Armstrong, for being with us today to speak about racial and ethnic disparities in COVID-19, how we can address disparities in health, and how we can better understand the role that racism and discrimination play in driving distrust.
So thank you so much, David, and thank you so much, Dr. Panos, for being the inspiration that you are to so many people, both across this institution and across the country. Nothing is a greater honor for me than to be asked to give a lecture about humanism and professionalism in medicine. And each time I think about that topic, I struggle a bit because it's so big and so important. And I think what I decided I'd like to do today is to really focus on this issue of equity and how can equity be a guiding light for us in medicine as we move forward. And so I am, as Dr. Cohen said, going to share some of my own experiences and work that have arisen out of the last year. It turns out that For somebody who's been doing disparities research for her entire career, this last year has certainly been a bellwether, a moment of understanding how this process, how this role that we play in medicine can really transform how we think about our roles as physicians. So I have no financial relationships. So I'm going to start with a patient. I think many of you experience this similar types of situations, but this is a patient who I cared for actually on the medical services back in April of last year. So a 47-year-old man who came to our emergency department with 10 days of fever and shortness of breath. He had been diagnosed with diabetes that year and was on insulin. He was born in Nicaragua, worked at Stop and Shop, and lived in Chelsea, which is one of the communities a little bit north of us, which has a very large Latinx population. Lived with his wife and 3 children. On admission, he was afebrile. You can see his vital signs there. He was already significantly hypoxemic, hypoxic on a non-rebreather. And his physical exam showed that he had scattered crackles. You can see his laboratories as we admitted him to the service. Significant evidence of inflammation. And as you can probably imagine, he was COVID PCR positive. And so this was the first patient actually who I cared for as we stood up surge teams, as I was actually assigned to overnight call, which I saw was a very brave part of my house staff to allow that to happen. And I think what he taught us was not only he and others like him, was many lessons, not only obviously the issues that we were going to face clinically in thinking about how to manage this disease, but it was patients like him that actually began to show us that the experience that Boston was going to have with the disease of COVID-19 was going to be one of massive inequity. And so what happened very soon after that was that the house staff on the services here at Mass General actually began to plot where our patients with COVID-19 were coming from. So they were able to get the zip codes of the patients and actually figure out what communities they were coming from. It was their observation that a predominance of the patients, particularly in our ICUs, were coming from Chelsea that led to this and many other analyses that documented that disparity. Here you can see, and I'm not trying to get you to see just this, you don't need to read all the names, although I was trying to figure out if there was any of the local communities here for Dr. Panos' ability to find himself on this map if he's up here now. But so if you can see, Chelsea is way up at the top here, with at that time New York being seen as the area of the greatest incidence of COVID-19. If you look down at the bottom, Wellesley, Arlington, Lexington, you can imagine the differences that we were experiencing. And so, of course, we saw this back in March as soon as it hit that we were going to see this significant disparity. But this disparity has then been borne out across the country as COVID-19 has swept the country. So this is just some relatively old data now, but it's not changed. With COVID-19 hospitalizations by race and ethnicity, I think what everybody knows and can see is that the rates were extremely different between whites here in the bottom kind of dotted line as compared to some of our other groups that are underrepresented in medicine or come from underrepresented backgrounds, particularly as we think about it for Blacks here in this line, American Indians and Alaskan Natives. I'll come back to that. It also turns out that that disparity in hospitalizations, of course, is echoed in mortality. I don't have to show you all of these data for you to see that we are finding much greater and have experienced extremely higher rates of mortality from COVID-19 amongst certain groups. So the remarkable thing for somebody who studied disparities for her entire career was not that this experience was being had, but that the level of attention that our community brought to this experience, so that we started very quickly across medicine and across the country to really ask ourselves what is going on, to really start to think about how we, when we had a signal of inequity, so here we had a clear signal of inequity, how we could stand up in medicine and say, what is going on and what are we going to do about it? So I will say that I'm going to talk through some evidence, both studies that we've done and other evidence about what we think might have been going on. I think many of you probably have some ideas already from the literature, from the press, from your own experience, but I want to talk through this mostly as an example of how we responded to this type of signal in medicine, a signal that you could argue is deep in the roots of humanism and medicine as we think about the role that equity should play. So I often group these things into multiple levels. Here I want to talk about 3 levels that may have been playing a role in this. So differences in individual characteristics, we often consider that kind of the individual level variables, differences in their healthcare or what was happening in the healthcare system, and then differences in household and community resources. So I'm just going to show some analyses that we did looking at household transmission. Some of this, I guess, has now been published, but that we did looking at household transmission. So what we did is we actually took all of our patients in April and May who had tested positive for SARS-CoV-2, and I matched them to everybody else we could find in their household. So we did that by looking at their addresses and then doing additional data collection to ensure they were in the same household. And what we were asking ourselves is, within a household that had somebody diagnosed with SARS-CoV-2, what was actually going to happen in that household in terms of the rates of diagnosis of COVID-19 of other household members, and what was, if we saw a disparity, which we expected to see, what was explaining that disparity. And so we did, as you might imagine, see a significant disparity in the incidence of COVID-19. So what this is saying is, if you had a household member diagnosed, what's the probability that you were subsequently diagnosed? For us, as I'd already shown, it was really our Latinx populations from Chelsea and around that were experiencing the greatest rates of diagnosis. It turns out that those numbers, however, the increased risk of being diagnosed with COVID-19 in our sample was not explained by the individual characteristics of those patients. And actually, interestingly, the patients were significantly younger. And so adjusting, even though they had some higher levels of comorbidities, adjusting for individual characteristics did not change the fact that in our populations, Latinx patients were significantly more likely to develop the disease. That was true here, and that has been shown in multiple other populations. So that does not mean, to be clear, that minority groups do not experience significantly higher rates of comorbidities. But what it is really suggesting here is that that higher rate of comorbidity is not driving at least all of the higher rate of COVID-19 diagnosis. Here's a large study of another large health system population. You can see that the odds ratio for hospitalization amongst COVID-19 patients, and the similar data existed for mortality, is essentially elevated no matter what is included in the model, including a comorbidity score. There's also been similar findings across the VA system. This is just showing you the same thing, that adjusting for all of these individual comorbidities did not change the fact that race, so here Black and Hispanic individuals, were at significantly higher risk of actually being diagnosed with COVID-19 in the VA. So if it's not, or at least it's not all individual characteristics, how much of this could be driven by healthcare, particularly differences in treatment and testing? So I just want to say that right now, and this is complicated because obviously much of this is coming out, and I'm going to show you some differences in how I think this may play out, or it has played out. But in many of the current studies, when we looked at patients once they were admitted to the hospital, there was very little evidence, including in our own system, that there were disparities in mortality after you were admitted. So once a patient was admitted, there was very little evidence that the treatment differed for a patient being admitted to the hospital. Here you can just see the hazard ratios for race of Black versus white in one of these other studies looking at that disparity. Of course, that doesn't mean that there's not differences in treatment, but as far as everybody could measure, the finding of differences appears to occur before treatment. So the risk difference is happening before we get to treatment. And I will just take 2 seconds to kind of editorialize that if you look at the history of disparities research in our country, one of the striking things about disparities is that the disparities are greatest when we have effective treatment. So I particularly have studied cancer for my career, and it turns out that the cancers where we see the greatest disparities are not pancreatic cancer or glioblastoma, where there is not clearly the most effective treatments, but it's in cancers where we have effective treatments. And so I think as we think about this model, I think it's important to recognize that even though we didn't find early evidence that the treatment differences were contributing to the mortality, as we develop effective treatments, that is when the risk of inequity occurs. And so we need to keep our eye on that ball. Just going to show you that the similar results were found across the VA with 30-day mortality here amongst patients who were diagnosed, not differing by race, as you can see here, just looking at the odds ratios here for race and 30-day mortality. I'm going to just show you that we had similar data within the Mass General. I don't want to go into this exactly, but we actually experienced higher rates of mortality, although they were not very different significantly with some of the groups, higher rates amongst our white patients once they were admitted to the hospital than we did amongst minority patients. I want to pause just for a second to say that the reality is that even though we think that there's not early evidence that the treatment was driving those early differences in mortality, that clearly there's issues with access to testing that happened over this period. We do know that one of the main issues that drives access, obviously, and I'll talk about that later, is the ability to afford the healthcare. So to the degree that our patients cannot afford their healthcare, it becomes almost futile to talk about how they will access such care. But because of the national mandate for testing, healthcare plans were required to cover testing costs, and funds were made available for provide testing to patients who did not have insurance. I will just say that it's still not very clear what access to testing was, despite these attempts to address the affordability of testing. This just shows one analysis from Kaiser about what the costs of testing are. And I'm sure for many people in the audience, they care for patients that any form of out-of-pocket costs at this level would have made testing prohibitive for those individuals. But the reality is that probably the affordability of testing, great efforts were made to try to address that. I will just say, and I'm going to come back to this later, as we think about what has been driving these disparities over time, I think there is increasing data, and this exists also for vaccination, which I will talk about, that the reality is that the distribution of resources is extraordinarily uneven. And it's uneven here, I'm showing you at a level of the United States. So we can look at this in terms of where the testing sites were particularly busy. So the idea being that if there's a long wait at a testing site, which is something that can be measured, it suggests that the demand is exceeding the supply, which suggests that there's needs for more testing sites. And so what you could see is that here in certain areas, particularly in South Texas, as they highlight some of the areas that really represent some of the most disadvantaged areas in the country, that there were testing sites were extremely busy. Now, of course, many other things drive demand, but I think that the reality is that if we look either at the national level or at the local level, and we've done many of these analyses in Boston, that actually the distribution of testing sites was uneven and unequal. And so it is entirely possible that as a community level resource, that access to testing was been contributing to these much higher rates of disease that we were seeing amongst minority populations. So I want to build on that for a second to just talk about this issue of community and household resources, because I think as we all are coming to understand that the reality is that differences in those resources are driving and did drive much of the experience of disparities in COVID-19. And I think provide a clear sign for us of the role that we can play in addressing these inequities in many of the diseases that our patients face moving forward. So I'll just show you, this is one small study. There have been many since then, but an early study that came out of Boston looking at issues about how community level, so here this is really looking at census tract level data about how community level factors were affecting the rates of diagnosis here in COVID-19. I'm not going to go through all the data, but I think you can see that for some of these level variables, so the average household size for the proportion of foreign-born citizens, we were finding a significant relationship between the community level variable and the rates of COVID-19. Similar data have now been shown for national and other areas across the country, suggesting that there are resource issues in a community. For us, of course, why does that happen? So you could imagine that there's a lot of availability here, or ability to access the types of things that are needed to prevent transmission. Here, particularly at that time, social distancing and personal protective equipment, which are essential for preventing transmission. And I think we understand that socially that ability varies by multiple things, financial resources being the ability to be an essential, or the requirement of essential workers, transportation, and household crowding. And I'll just show you the data that we have actually, or the results from our own study. And what was remarkable to us when we actually looked at what was explaining the difference in racial and ethnic transmission within households, the remarkable thing is that very little of it in our study was actually explained by variables at the community level, at census tract or zip code. But in our population, an extraordinary amount of the variance was actually explained by the household level. So 40% of the variance was explained by the household. So what that means, and interestingly for us, it wasn't related to the number of people in the household or even whether there were children in the household. It was related to differences in the household ability to manage exposure, people's need to go out for work, differences in the ability to get access to resources to prevent transmission. And so those were the issues. It was within a household. Did you have the ability to get access to those resources? So I'm just going to show you quickly some national data about these things to emphasize that point, This is something I think that we all know. I think it's always more and more striking when I look at it here in Boston. I think in Boston, there's some data that suggests that the net worth of families, of African-American families, is measured in the hundreds of dollars compared to the net worth of other families measured, as you can see here, in much, much higher levels. This just talks about differences in household income, which of course are influencing household resources, as well as differences in checking account balances here down on the bottom, and differences in net worth. So we all know this, but I don't know in our lifetimes that we have ever seen this play out as quickly in terms of the effect on disease and mortality in the patients that we care for, as we saw over the last year. I also want to bring up that we all recognize that during a pandemic, there's a particular risk to your types of employment. I think these are national data that just show the job characteristics by race and ethnicity, non-essential workers being able to work at home being greatest in certain groups. And then if you look at the essential workers unable to work from home, healthcare, you look at the groups, the stars just talk about statistical significance, but you guys can see just looking at this, that there's a far greater proportion here of essentially individuals unable to work from home who are in Black and Hispanic groups. There's similar issues with transportation. We think about the looking at how people use transportation, often not a major factor in our health, but an enormous issue during this early phase, particularly here in Boston. And as you can see, the public transit use varies by groups. Here you can see much higher amongst Blacks, particularly, and this is in urban settings. And then you can see that played out here in terms of the transit, the differences in the distribution, differences in the distribution of the ethnicity of populations using transit compared to the US population. So I think what we saw really, actually I'll finish here by just talking about household crowding, which has received a lot of attention. Interestingly, what we saw in our communities was that people were actually self-spreading out across households. This received a lot of attention early. And so people were moving family members to areas to try to protect them from household crowding. But I think, as we all know, family size and household crowding, if you think about it, varies by race and ethnicity. These are just some data here that talk about the proportion of households that are living with numbers of members by different rates of race and ethnicity. I'm going to share that we spend a good bit of time working with American Indian populations. And I think that was a really interesting phenomena at that time within some of the Lakota tribes who were trying to manage this risk by actually being able to take advantage of the fact that they have relatively low household density to manage the risk as they were seeing it come to their communities. We also know that the proportion of individuals in multi-generational households has been growing, particularly in certain groups here in Hispanic and Blacks. And then, of course, the reality that our patients from different races face different levels of inadequate housing. So simply in housing that is not able to provide a safe environment. And so as we looked in our population, even though there were differences in individual characteristics, and even though we believe that access to testing was a community resource that was not equally distributed, it was clear that what was driving that first signal that the house staff picked up on our medical services was these issues of household access to resources, the need to work outside of the home. And so I think as we started to recognize and talk about that, I think it really brought us back to this concept of structural racism that has been discussed in many areas across our society for some time. But I don't think we have ever seen it play out in the way that it did, both through COVID-19 and of course through the police violence that was happening over that summer. So structural racism is really an invisible, in many ways, force that is the totality of the ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, and I don't need to read to you all of these others. So these patterns and practices in turn reinforce our discriminatory beliefs and stereotypes, values, and particularly this issue of distribution of resources I want to emphasize. So some of the ways that structural racism works are very apparent to us, and I already brought that up, but I just want to emphasize that we think a lot about the obvious ways. So I think as physicians, we advocate for our patients to get access to the care they need by insurance and other types of coverage. I spend a lot of time filling out forms, different than when I was in Pennsylvania, to move from a state that had significant rates of uninsured to a state that has almost no uninsured has been a transformative experience as a primary care provider and as on the inpatient medical services. I think for all of us, we recognize the reality that having insurance is fundamental to being able to get access to the care that you need to save your life. But it turns out that there's other ways that I just want to emphasize for a moment that really are equally important as we look at it, but are sometimes less obvious. So I want to spend a second to talk for about something called racial residential segregation that we've studied for a long time, that has an enormous effect on the distribution of resources within a given city and how those resources are accessible to our patients. So residential segregation is essentially the ways that racial groups are distributed in their housing across a city. And they can be measured in multiple different ways, and I'll show you some of that. But the reality is that we can look at it sometimes on maps. So here's a map of Detroit, and the darker green, the census tract, the greater proportion of African Americans. And you can see here, I think, the fact that there's extraordinary concentration of minority populations in Detroit, which interestingly is different than when you look at a city like Charlotte that still has some levels of concentration, significant concentration, but is going to have a different level of distribution of those groups in the city. Well, there are many ways that segregation affects how we think about healthcare. And I want to just show you a study that we did some time ago. It's a little bit hard to see, but we all in healthcare make decisions about where to open our new clinics. So it's something that happens all the time. And actually, this was a time back in the mid-2000s when there was a large emphasis in opening what were considered retail clinics. So essentially almost like minute clinics where people were going to come in, be able to get access here now to COVID testing, let's say, but at that time to kind of rapid access to healthcare. And the argument that was being made at that time was that those clinics were being made to improve access for everyone and were going to be put in disadvantaged areas. And that was the argument that enabled many cities to go ahead and approve this to move forward. I think if we just picked a number of different cities and looked at where were those clinics actually located. And I think what you can see here in Orange County, California, Harris County, Texas, that the dark gray areas are the medically underserved areas. So if you look at these areas, these are the areas where you could measure the need for access to primary and other care. And then you can look at where they actually put the minute clinics. And I wouldn't say it's a completely unoverlapping area, but it is close. And so if we think about segregation, one of the realities, and we talked a lot about this as we were thinking about issues of vaccine distribution nationally and other areas, that if you only can give vaccines or testing in the areas that are already built, so in our current minute clinics or in our current structures, we are automatically leading to an inequitable distribution of those resources because of the segregation within most US cities, leading to this type of disparity. But I want to also bring up that it turns out that segregation works not just in the way that resources are distributed across cities, but actually in the level of segregation within the city itself has an effect on access to healthcare, both for Blacks and whites. So the more segregated a city is, the less people appear to be able to access some forms of healthcare. And I think there's some realities to how that influences the distribution of resources that we're just starting to understand. So this is a study that we did of segregation and access to cancer treatment. What you can see is we've taken the large cities across the United States and we've essentially categorized them in terms of their levels of segregation. I think you can see that there's actually an interesting distribution of both lower segregated in this light yellow and higher segregated in this kind of pink across the country. And now if we look at it, this was a study analysis. I'm going to just show you a prostate cancer treatment, but we have similar data for other types of cancers. We look at it, if we took men who had early stage prostate cancer, we identified over the age of 65 from Medicare files. And we look at it, we compared Black and white men, and we're asking ourselves, does segregation of the city influence their likelihood of getting treatment? And what you could see at that time, I'm just showing that there were significant differences, as you could imagine, between Black and white men. And I just want to bring up that one of the key issues is that given if segregation has a negative effect on our healthcare systems, then Blacks were living in cities, here measured by an isolation index, one of the measures of segregation. Blacks were living in cities that actually had a much higher rate of segregation, so 0.65 versus 0.48, so that Blacks are experiencing higher levels of segregation. In this analysis, and there's many others we've done, it turns out that there were significant differences between Blacks and whites within their treatment for prostate cancer. These particular data come from some time ago, before when we were still, I think, more aggressively treating early stage prostate cancer. But as you can see here, Black men in the yellow were much less likely to get active treatment than were white men in the orange. And it turns out that, interestingly, what we discovered was that segregation had a negative effect on both groups. So both Black and white men were less likely to get access to treatment within their early time of being diagnosed after developing prostate cancer. But the effect was probably greatest, interestingly, in prostatectomy amongst Caucasians, and for radiation, the effect was greatest amongst African Americans. And so the reality being that segregation affects not only races in terms of the distribution of resources within a city, but appears to affect the actual treatments that both Blacks and whites, as well as other racial groups, experience for cancer and other diseases. So I want to bring up one critical issue, because I spend a lot of time working with scientists across Mass General and Harvard who do science, convinced that we are going to be able to change the fundamental immune biology, to develop new therapies that will change our genes, to change every part of the inflammatory cascade. And that level of dedication has had incredible results in terms of new treatments, has changed our way of being able to treat cancer, to treat COVID-19 or prevent COVID-19. But the reality is that one of the things that is always so striking to me is that as a healthcare profession, we often feel more empowered to take on these scientific and biological issues than we do the issues, the social issues that we have ourselves created. And so the reality is that healthcare segregation is not a biologic phenomena. It's a phenomena that has been created by long centuries of redlining of where different groups were able to purchase property. So I just picked one map. This is a map from Essex County, and I'm not going to be able to get the New Jersey, trying to come home closer to you all. But I'm not going to be able to get the date on here, but I can tell you it was a while ago in the mid 1900s, essentially. What this is that then when you were actually trying to buy a house, that all of the different, all of the governments as well as all of the banks would actually create these maps that showed you where it was safe to live, that was the blue and green, and where you were not able to be safe to live. And as you can imagine, the one thing that was driving that was the color of the people in those communities. And so this is actually, as I understand it, Newark, and it was considered exactly redlined, as the words would said, in terms of who could buy property there. And nobody would actually pay for people to buy houses in these communities. And so you could imagine that even though we think of this as some kind of immutable force, that actually these social forces were man-made and continue to be made by men and women today. So these inequities in health outcomes are not accidental, random occurrences experienced by people who happen to be in the wrong place at the wrong time, but they result directly from longstanding discriminatory public and private policies, such as segregation. And so I think the lesson for me, I just want to bring and will continue to emphasize, is that what I saw in COVID-19 was that the medical community began to understand that actually these two, not just the immune system, but these social forces were both under our, and when I say our, I mean societal, actual influence, and that we had an ability to change the trajectory of inequity in health in our country. I want to talk for 2 seconds about another force that I think has a major impact here that is often less apparent and that I've spent a lot of time studying. I'm going to emphasize that as we think about the disparities that are now being seen with COVID-19 vaccination. I don't have to show these data. You all know that there's been lots of attention to the differences in the levels of vaccination here between whites at 35%, Asians at 39%, and then Blacks and Hispanics at 22%. So there are many reasons for those differences, and I think it's important to recognize that some of that relates to all of the resources that I have just talked about. But I think there's also a big attention to the reality that for many groups in the US, that actually undertaking a novel treatment or a novel intervention happens on a background of significant distrust that exists related to healthcare in the US. So what is distrust and what can we do? So the distrust is really the idea and the belief that others are going to act against your interests. We know that trust is central to medicine, central to humanism and professionalism. It's a part of our relationships with our patients. It turns out that many people have also shown that trust and distrust are central to all aspects of society, and that as you grow distrust, the reality is that it creates cost to all transactions. It makes it harder for everyone to get what they need, including vaccination. We also know that the healthcare system exists in a historical and social context. And the key issue here is that there's a long history of that context of the healthcare system acting against the interest of minority patients. And that we know that it may serve then as a hidden constraint on vaccination and create disparities. Interestingly, for me, the first study I ever did was as a resident on the Hopkins Medical Service. And for all the residents in the audience, I think you will recognize that as you're a resident, there's things that make you angry. And one of the things that I remember being very angry about was that I was constantly in trouble as a resident for the fact that not all of, because I think we had a quality metric about influenza vaccination, And I was in trouble that not all of my patients were willing to get an influenza vaccination. And I remember the leaders meeting with us and saying, you've got to get them to get a shot. And so I decided to do a study to try to understand why we were seeing refusal of influenza vaccination. This was back in the late 1990s. But I think it's very similar now as where we are today. And what we essentially showed is that actually an MD recommendation does make a big difference to whether people got a flu shot at that time. But mistrust of shot contents, the belief that there might be something in that shot that was going to hurt you, was extremely important and actually cut the probability that somebody would get the shot in half almost. And so, of course, yes, we think about these issues of it being painful or inconvenient, but the reality was that having this belief was almost as important as any of those other things that receive much more attention. I also want to bring up that we know that in general, that specific issue is within a context of overall differences in trust of both physicians, and I'm going to show you some about the healthcare system. So actually, we've done, these are two of our studies that just show that African Americans have higher rates of distrust, or here low trust in healthcare providers. Here a 50% increase amongst African Americans versus whites. Here another study that just shows that if you measure it as a distrust score, higher rates both amongst Blacks and Hispanics in this large study across the US of the community tracking study. We were particularly interested as we think about issues of vaccination or new technology and the role that the healthcare system may play in distrust. And we think that this distrust of institutions may be particularly important in that area. And that may include the reality that these efforts are seen as belonging to hospitals, insurers, pharmaceutical companies, and their motives for getting these done. We developed a scale or looked into measuring this and discovered that actually there are two main different domains as we think about trust amongst our patients. And I want to emphasize this as we take care and move forward clinically. The first is that we ask our patients to believe that we are competent, that we're actually able to deliver what they need, and that we will do that in a safe and effective manner. But the other is really this key issue of values, that we have to show our patients that we have their interests at heart and that we behave solely on the basis of those interests. We created a scale that included 10 items. I'm just showing you a few of the items here. But I want to show you, and we've done this multiple populations, but just some of the results of that study and of studying healthcare system distrust, because they're a little bit different than what I expected. So it turns out that if we study distrust across racial groups, and here particularly between Blacks and whites in the US, that there are actually higher rates. The differences in overall scores are there, but small. Where the difference occurs is really in values distrust. If we look at competence distrust, there's really no difference across groups. And in fact, most of our studies, I don't show this here, show higher rates of competence or lower rates of competence distrust amongst Latinx populations in our country. But this issue of values distrust, and particularly these two items, that the healthcare system is lying to make money, and that's one that we see now playing out in vaccination, that the healthcare system is experimenting on patients without them knowing it. Those issues are driving an enormous amount of the differences in distrust that we see. But I want to make another point here, which is the reality is that distrust, just like segregation, is not some biological phenomena. It is a phenomena that has been created over generations by experiences of racism and discrimination in the healthcare system. It is a completely rational response to the way that populations and groups have been treated. There's a phenomenon called lay epidemiology, which always says if you see bad things happen around you, you are going to make assumptions and make inferences about why those are happening. And so we did a study that looked at what was the relationship between having had an experience of racial discrimination and levels of distrust. And what I want to point out here is that if we're just taking, and this is an analysis again comparing African Americans to whites, and this is all self-identified race in these analyses. So these are from patients self-identifying their racial groups. We found that if you look at it and you just adjust for these individual characteristics that we talked about before, including comorbidities, that there's higher levels of distrust amongst African Americans. That doesn't change if we add in factors that include whether or not people are able to get medical care, here down the bottom, health insurance, whether or not they've had trouble with a collection agency, it's about the same. But it actually flips if we add in the experiences of racial discrimination from a validated score. So it is experiences of racial discrimination, both within and outside of the healthcare system, that are driving these differences in distrust. So I want to finish by just saying that for me, the examples of the last year have really been that we can do something about this. That if we think about segregation, or if here we think about distrust, it's a symptom, not the disease. It's a sign that the system has not been trustworthy and that we can fix it. And so I just want to finish by showing you some of the ways that I have been so inspired by thinking about how we, people, physicians, systems across the country are standing up to do something to make a difference at this time. So I think as we think about lack of community resources, it was striking to me that within almost weeks of identifying that first slide that I showed you of the differences in rates across communities, that the residents here, I'm showing you residents from the Mass General, but this happened across the country, that they came together to figure out how to deliver both PPE and other supplies to communities. I don't have a slide here, but within the work that we're doing in Lakota, with Lakota tribes, the amount of actual resources that were moved out to households that had none during that period was staggering, enabling people to get food and all sorts of access to things that without which clearly the rates would have been much higher. And so that role is clearly not going to happen in this way forever, but taught me that yes, we can change the ability for our households to get resources. I also want to bring up work that we and others have done, because the reality is that healthcare segregation, yes, it's driven by residential segregation, but teaching hospitals and academic medical centers have forever played a critical role in overcoming and reducing healthcare segregation. And that because teaching hospitals have traditionally been located in inner cities, they have cared and provided outstanding care for disadvantaged and racial and ethnic minority populations. I'm just going to show you one analysis that we did that actually showed that if we looked at patients who had localized prostate cancer, back to my cancer research, and where they got care, that they actually were much more likely to get it at a teaching hospital. And this role of academic medical centers is something we cannot take our eye off as we think about where we, both here and in other academic centers, are locating our hospitals and our clinics. For me, part of that argument has been arguing for community engagement. How do we actually get our hospitals to want to engage in these communities? I'm just showing you one study quickly that we did that showed that actually hospital community engagement was a major determinant of where a patient goes for surgery. Hospitals care about where patients go for surgery because they bring in high margins. And here I can show you that if the hospital had a high level of community commitment, patients were more likely in a national sample to go to that hospital for surgery, arguing that actually investing in the communities is good business for these hospitals. So I said we have also spent time working on how can we in academic medicine actually go to the areas of greatest need. I won't talk a lot about this, but to say that we have actually begun programs helping in South Dakota, where the mortality rates are the highest among some of the Lakota tribes. And I think the opportunity in this global world to be able to think about how to take advantage of telehealth, other forms of relationships, to actually go to the areas of greatest need really took off for us over the pandemic. And then I'll just finish by saying addressing discrimination is critical. So we've been working on bystander intervention, and even though we've done training, it did not seem to be changing it. So bystanders, so we asked ourselves, does knowledge, or was it that people don't really understand the level of structural and other racism that is going on? And so what we did is a study of all of the members of the department. And what we asked is, how likely is somebody to speak up when they saw a racist incident, when they actually speak up to the person who did it, or to leadership, or when they saw a policy that reinforced racism? And what I want to show here is just that knowledge of racism and health was driving across all groups the reality of whether they spoke up. And so we are now addressing that, creating programs, as I'm sure you are, to increase knowledge about discrimination and health, to have everybody do implicit attitude tests, to change the culture in the department and in the institution. So I'm just going to finish by saying that I think COVID-19 has called attention to disparities in health and healthcare in ways I never expected. That these disparities come from things like differences in community and household resources, and racism and discrimination. But what it has done is it has shown us that both biological and social approaches are actually under our control and are central to our role as physicians. And I believe it's shown us that we're capable of far more than we ever thought we could be. So I'm going to just thank you, and I know that I hope we still have a couple of minutes, David, for questions here, but I just want to thank people for inviting me. My fervent belief is that there's nothing more important that we do as physicians than address the inequities that our patients experience, and that without doing that, we can never hope to achieve the levels of humanism and professionalism that I am sure is what this group stands for and what this lecture is about. So I'd be delighted to take any questions.
Oh, thank you very much, Dr. Armstrong. That was powerful and definitely very eye-opening. Before we get into a couple of questions and comments, you talked a lot about social determinants of health, access to care, and it was interesting what you showed about mass transit and use by race and ethnicity. I'm wondering if there's any research you've looked into, or if you can shed a light at all on also use of interpreter services and how language differences is a barrier to care.
Yes, David, it's such an important issue. And as you can imagine, when you start down these narratives, there's so many different issues that end up coming up. So I think we have very strong data, and I didn't have time to show this, but one of the things that we've done at Mass General that I have benefited from is to be able to actually report all of our quality metrics by equity. So we report it by both race, but also by language. So both English proficiency and native language. And I think what we discovered, David, is that during the pandemic, the disparities that we had previously been able, I think, to minimize by having interpreter services, by having a large range of options for interpreters, really grew because the interpreters were not in the hospital. We were having much greater issues with getting access. And so we actually created what was called our Spanish language physician service or something like that, where physicians who spoke Spanish volunteered and were matched with every floor to actually come in and serve as interpreters during this time, particularly, as you all imagine, for some of the incredibly hard discussions that were happening about goals of care during the initial pandemic. And so there was very good data, I don't have time to show it, that Spanish language service transformed the experiences for our patients far beyond trying to get somebody on the phone or an IPOP or all these other things that was just not happening during the pandemic. So I think it's absolutely critical. I will say, maybe on my personal journey, is I'm really digging into learning Spanish. I can speak some Creole, but speaking Spanish has somehow never been my thing. And so that was my personal journey, is that if I'm going to practice, I need to speak Spanish.
Great, thank you. Dr. Weber, you had a question?
Yes, so thank you, Dr. Cohen. And first, I want to say a special hello to Dr. Panos, who I had the privilege to train under as an intern and resident in medicine. Dr. Armstrong, thank you for such a powerful and I'll say enduring presentation. A couple things really came to mind as you were speaking. First, once you were describing redlining and structural racism, I think really you gave us a wonderful overview of structural competency as a whole, simply because of the covering, as Dr. Cohen said, structural, socioeconomic determinants of health and so on. But the two questions I had for you were technology. When you talked about upfront, when you have best treatments or state-of-the-art treatments in areas and how that leads to disparities, where do you see technology coming in, including artificial intelligence? Is there a high risk of a digital divide or a similar approach as you see with treatments?
Well, so Dr. Weber, I think it's such an important issue. I was saying it's such a great question. I mean, you're going to discover that despite, or maybe it's apparent, that I am a cup half full person. Like, I am an optimist. I believe that we actually have the ability to fix this, and that we created it, we can fix it, just to be 100% clear. And so, I think if we look, I'll give you a couple of examples. I actually think that, and I'm sure you guys are experiencing the same thing, that when we look at our ability to do telehealth over video, that we do have significant gaps in our ability to do that. But then when we actually look at our ability to access patients with texts or phone calls, that actually we are seeing very good uptake amongst essentially every group, and sometimes better, right? So I don't have to show you guys because I'm sure I shouldn't be doing this, but there are certain patients in my panel that I essentially can only reach by text. Right. And they are the lowest income patients in my panel. And so they have my cell phone. Maybe I shouldn't tell you guys this, but I am going to get their text and I am going to reach out. Many of them are on Suboxone, actually. And so for me, it's critical that they have access to the system. So I think technology, if we start with a belief that we are going to use this to fix inequities, as opposed to starting with the belief of letting it play out, right? Like, if we come into it saying, how are we going to do this? I'll give you an example. So we have a project that's is trying to work on developing palliative care on the Lakota tribes in South Dakota. And I can tell you that out there, if they didn't have access to basic just cell phone technology, there is no way they would be getting what they need in terms of palliative care. And so I think we can use it to bridge the digital divide, but if we don't actually make that a priority in what we're doing. So I would argue for you all at your institution, equity is one of the dimensions of quality of care. It is in the Institute of Medicine. It is critical. And so we should measure equity just like we measure everything else, safety reports, everything. And I don't think we should be okay if it creates inequities, because the reality is we can fix that.
Yes, thank you. And David, I'll turn it over to others.
Thanks. Sarang, Kim, you wanted to ask something?
Yeah, I just want to say hi, Katrina.
So great to see you. Sorry, this is like old home day for us.
Yeah, I mean, Katrina was such a source of inspiration to everyone at Penn. And so I'm not at all surprised that you're so inspiring. And I really just wanted to make a comment that all of these talks that we have had, we've had many talks about disparities and health equity. I think when we talk about systemic racism, we're talking about the fact that the system needs to be fixed. And what I particularly appreciate are all the examples you've given about what individuals are doing. I'm so impressed that your residents started drawing a map of where the patients were coming from. I think that's, when we hear about systemic racism, I think we feel powerless often. So I really appreciate all the examples. I think I'm impressed that you're giving your cell phone numbers to all of your patients. I do that on a very selective basis. But if we're trying to improve access, that might be one thing to try. So if you had any other examples of what you've seen your colleagues do, that would be really wonderful.
No, absolutely. And I think, Sarang, I couldn't agree more with that statement. And I think part of the reason that I have gotten so engaged in this effort over the last year is that I had this like aha moment, because I actually gave the graduation talk to Penn Medicine like in the spring over Zoom for the first time. It was a total disaster, actually, just in terms of like the actual logistics. But what was fascinating to me is I realized as I was talking to people and preparing for it, that all of those medical students thought they were going to go out and like create a new cancer treatment. They thought they were going to change the genome. They were going to like figure out a PD-1 inhibitor. They were going to find a new target. Like they were convinced that human biology was completely modifiable. Does that make sense? Like that we could fix physics, right? It was like crazy. But if you talk to them about the concept that a patient didn't have access to a medication, they thought that was completely beyond their control, that they had no influence and no ability to change that. And I think it's that shared sense of helplessness that we have to get over. And so I guess, Ron, my advice is that everything makes a difference. So if we as a medical community stand up and say that it is our professionalism, I'm not suggesting that we start building apartment buildings, but it's our professional responsibility to take on equity, and that we each do something that actually, it's changing the shared sense of helplessness. Does that make sense? That I think is absolutely critical here. And so that's why I've become just so adamant about talking about what's happened over COVID-19, because we did do all these things, right? So we had patients, we had medical students essentially all over doing crazy things, taking care of children, monitoring hotels, bringing out-to-sat machines to people everywhere. We had people developing food banks. We had an enormous belief that they could do something. And so I think for each of us, I don't want to say it's going to be the same thing, but I think if we each took one step, it's not only the step, it's the belief that we can do it that will matter.
Hi, Dr. Armstrong. Thank you so much. This is Renita. Really appreciate it. I had a question. And when you talked about competence and value, under the value schema, you talked about our healthcare system being profit-driven and so forth. Is there an elimination of that contribution where there's national healthcare systems like the UK?
Yeah, so it's interesting. If you look at that, yes, is the short answer. That if you look across countries, that I want to be clear, every country that we can measure, people have issues with their healthcare system, right? I think it's a little bit like a marriage, right? Like it's always going to be complicated. So I want to be careful about saying that there's like, one way that we have somehow proven works. But I do think that if you look at the primary issues with the US healthcare system, that values distrust is really driven much less by a sense of, it's driven by a lot of concern about profit motives. Now, I want to be careful because actually we got involved in some studies early on, actually in South Texas, where we were trying to understand how do patients make these decisions. And the reality is that nobody thinks that doctors and physicians and hospitals and healthcare systems should not make money. In fact, our patients often believe that one of the things I love was that if you asked a patient in some of these communities how they picked a doctor, they said they picked a doctor who had the best car, because the doctors with the best car were doing the best work in their perspective. So that was their signal, was to pick a car. Of course, I still like drive Toyotas, and so that maybe is not good for my patient process, but so I want to be careful. Nobody thinks that people shouldn't make a profit. I think the concern is when we hide the profit motive or when it's embedded in decisions that are not apparent. And when that happens, they don't think that we can actually be trusted to be making their decisions, to be helping people make decisions in that way. And so I believe that academic medicine has a particular role in speaking openly about the fact that there is no perfect way of financing healthcare, but we have a responsibility to be honest and transparent about where different motives are coming in. Clearly, in many systems that are run by national systems, there's significant concern about rationing of healthcare in other ways, right? I just want to be careful. But the reality is that if we talk about these things, we will do better.
Great, thank you. Manish Patel had a, sorry, Dr. Armstrong, I don't want to keep you.
No,
well past
actually,
the-
the meeting I'm supposed to be on, I'd so much rather be here.
Oh, maybe we'll finish up. Manish Patel had one question. We can finish up with him.
Oh, hi, how are you? Can you hear me guys okay?
Yes.
So again, really amazing talk. Thank you very much. I'm one of the general medicine hospitals faculty, just to give you a quick background. But as you described and as has come out more and more, obviously these disparities are systemic and will require real structural change. But given the urgency of the pandemic and the urgency of the need to get the population vaccinated, what would you recommend to increase the rates of vaccination in these minority communities now, especially in the face of this distrust? So how do we gain this trust in a more short period of time?
I mean, I'm going to say that I actually am in the camp that this is like, I forget all the different words, that this is kind of vaccine delay, not vaccine refusal. So when I talk to both all of my colleagues here across the food services, all of the folks who are facing some of these questions, when I talk to patients, I actually think that what we're going to see over the next months is really a very rational response from communities that have traditionally been at the forefront of negative outcomes from adverse events, to be clear. So communities that have traditionally experienced worse outcomes from healthcare. So Manish, my guess is that if we stay the course, we provide open and easy access and choice. I didn't have time to show studies, but actually one of the interesting things is if you look at new technologies, we've done these studies, that many groups are much more likely to get those new technologies if they come from a known relationship with their primary care provider. So that I believe if we can get vaccination into our primary care clinics, into community health centers, if we can actually stay the course, that we are going to see what I think was a very rational response to a new technology actually start to flip to that point. That is different than certain other groups that I think have what I would call an irrational response to this new technology, and so there are groups that are going to continue to refuse vaccination. And I think those issues are very complicated. And, I think we're going to have to come together as a community. And I don't know where your hospital is on this. I've been advising a lot of universities, including Harvard, and there's lots of discussion about mandating vaccination for different groups. I mean, not different groups, but different activities. And I think the challenge that we have, just so you all know, is that if you show data where you mandate or regulate something, distrust actually goes up in that setting. And so the paradox is that if we have to move to mandatory or regulation in this area, that we may fix this problem, but we're going to pay for it later. And so the reality is my hope is that we can somehow thread the needle where we actually do get people vaccinated without going there. But I'm optimistic, Manish, that the populations that have traditionally been, I think, wise enough to wait and watch are going to start getting vaccinated.
It's actually very heartening because,
But just
as
to be
obviously
clear,
those of
Manish,
us, yeah,
doctor recommendation is the #1 driver of all good things in the world. And that's
Yeah,
why being a
yeah.
doctor is one of the greatest things that you can ever do. Because when you tell a patient that you believe it's right for them to get vaccinated, that changes what they do. And so I just would say for everybody on this, I take every moment to reach out to anybody. I walk by in the corridor and say, have you been vaccinated? Do you have any questions? And so just, I would strongly encourage all of you, it's a hand-to-hand game here, and every piece that you do matters.
Yeah, I draw a line to smoking cessation in that regard, where even simple brief advice from your physician, from other healthcare providers makes a huge difference. And it would be interesting, piggybacking what you said, is there are, as you know, Rutgers led the nation in mandating vaccines for students coming back to campus in the fall. And so I wonder, when you mentioned about how if it will drive more distrust or solve problems, I wonder where this is going to fall out.
Yeah, I
But
mean, in
anyway, it's
general,
more of a comment.
we don't worry about students as much. My kids are all college students. I mandate they do a lot of things. So, but I agree with you, Manish. And so, David, I'll stop there.
Thank you so much. It was a great way to end, inspiring way to end inspiring talk. So thank you very much, Dr. Armstrong, for a wonderful time.
Thank you for having me. Bye-bye, everyone.